This is the full dose of gout and hyperuricemia from Therapeutics Drive clinical learning for pharmacists on the go. This is part of the Therapeutics Drive podcast.
Yeah, and I think we really need to set the scene for this one.
Right, absolutely. So imagine a patient walking into your pharmacy right now. It's, the air conditioning is blasting, but this person is visibly sweating.
Mm-hmm. We've all seen that patient.
Exactly. And they're wearing a normal shoe on one foot, but on the other, they're wearing this oversized, unlaced sandal, or, maybe just a loose sock.
Or honestly, sometimes they're terrified of even that loose fabric touching their big toe because the pain is just that excruciating.
Yes, it's agonizing. So for you, the practicing pharmacist, whether you're stationed in a busy community pharmacy or maybe you're rounding on the wards in an Australian hospital, our mission for this deep dive is to completely master the clinical management of the condition causing that exact agony, which is gout.
Right, and it's incredibly common. I mean, if we look at the NSAIDs data from around 2015 to 2016, gout affected about 9.2 million adults.
Wow, that's huge.
Yeah, that's nearly 4% of the population, and it heavily skews toward men. But despite us seeing this literally every single day, we're constantly battling these three massive misconceptions at the counter.
Oh, the misconceptions are everywhere. Like patients and honestly, sometimes even clinicians operate on this belief that diet alone causes gout.
That's a huge one.
And the second one is we see patients desperately stopping their urate-lowering therapy the absolute second they feel a flare.
Which is the worst thing they could do.
Right. And then the third, which is maybe the most dangerous one, is assuming that a normal serum uric acid level in the emergency department means that swollen toe must be, something else entirely.
Yeah, and what's fascinating here is how completely backwards these misconceptions are when you actually look at the pathophysiology. Blaming diet alone, I mean, that completely ignores the evolutionary biology and the complex renal physiology driving the disease.
It really does.
And that instinct to stop a drug like allopurinol during a flare, that actually prolongs the attack. You're just destabilizing the joint even further.
Because of the crystal shifts, right.
Exactly. And relying on a normal uric acid lab value during a flare, that is perhaps the most common diagnostic trap in clinical practice today. Unlearning these traps and, understanding the molecular why behind them completely shifts how you assess the patient standing right in front of you.
I love that because my whole career, I've heard gout referred to as the disease of kings. You picture King Henry VIII eating huge platters of organ meats and drinking port wine.
Right, the gluttony stereotype.
Exactly. It's been treated historically as this isolated, almost comical disease of the foot. But that historical baggage does a huge disservice to what is actually a really devastating systemic condition.
It's extremely systemic.
So before we fix the medication errors, we need to define what we are actually treating. We tend to throw around gout and hyperuricemia interchangeably, but they really aren't the same thing, are they?
Not at all. Hyperuricemia is strictly a laboratory value, period. It's defined as a serum uric acid, or SUA level, exceeding 6.8 milligrams per deciliter.
Which is roughly 404 micromoles per liter for those using those units.
Exactly. And that specific number, 6.8, that's the physical point at which uric acid reaches its solubility limit in human blood.
Okay, so it just can't dissolve anymore past that point.
Right. Gout, on the other hand, is the clinical inflammatory reaction. It is the intense pain, the erythema, the immune system destruction that happens when that uric acid precipitates out of the blood and deposits as solid crystals into the joint space.
Okay, so high uric acid doesn't automatically mean you have gout.
Exactly. Only about 20% of patients walking around with asymptomatic hyperuricemia, meaning, their lab value is over 6.8, but they have no pain. Only a fifth of them will ever actually develop gout within a 5-year period.
Which means if I see a patient's routine blood work, and their uric acid is, let's say, 7.5, but they've never had joint pain in their life, my instinct to just start them on a prophylactic drug is wrong?
It is entirely wrong, with very, very rare exceptions, like tumor lysis syndrome in oncology, which is a totally different physiologic crisis. You do not treat the number if there are no symptoms.
Good to know. But going back to your point about the disease of kings and how we view this, viewing gout as just a sore toe really misses the entire systemic web of this disease, right?
Oh, absolutely. When that limping patient approaches your pharmacy counter, you shouldn't just be thinking about their foot. You really need to be thinking about their kidneys, their heart, their metabolism.
It's all connected.
Deeply connected. Gout is intertwined with chronic kidney disease, type 2 diabetes, metabolic syndrome, and obesity.
I always just assumed the kidney damage was basically a mechanical issue, like
Yeah.
the uric acid literally forming stones that physically scrape up the renal tubules. But the cardiovascular risk, I mean, that seems out of left field. Why is gout considered an independent risk factor for coronary heart disease?
It all comes down to endothelial dysfunction. Uric acid is a really bizarre molecule. When it's out in the extracellular fluid, it acts as a primary antioxidant.
Which sounds like a good thing.
It is, until serum levels get too high. When there's too much, uric acid gets transported inside the endothelial cells lining our blood vessels. And once it's inside the cell, it flips. It becomes a powerful pro-oxidant.
Oh, wow. So it actively causes damage.
Yes, it decreases the bioavailability of nitric oxide. And we need nitric oxide for our blood vessels to dilate and remain flexible. So when you lose that, it triggers oxidative stress, vascular stiffness, and actively promotes atherosclerosis.
That's terrifying. So the swollen toe is really often just the canary in the coal mine.
Exactly. It's an alarm bell signaling that the patient's entire vascular system is under profound biochemical stress.
Okay, so if we are dealing with a molecule that can stiffen blood vessels and destroy a joint, we really need to trace where it actually comes from because humans are somewhat unique in how we handle uric acid, aren't we? Like most mammals don't get gout.
They don't. Most mammals have this enzyme called uricase. And uricase rapidly breaks down uric acid into allantoin, which is this highly water-soluble compound that just gets effortlessly peed away.
Right, so why don't we have that?
Well, during the Miocene epoch, which was roughly 15 million years ago, early apes underwent a genetic mutation that basically silenced the uricase gene. We lost the enzyme completely.
Wait, really? Why on earth would evolution select for a mutation that literally gives us painful crystals and stiff arteries? That makes no sense.
It does if you think about survival during global cooling. Without uricase, our uric acid levels naturally run higher than other mammals. And uric acid actually enhances the foraging instinct. And, crucially, it amplifies the conversion of dietary fructose into stored fat.
Oh, so it helped us store fat for the winter.
Exactly. Millions of years ago, when fruit was scarce and winters were starving our ancestors, the apes that could rapidly convert sparse fructose into fat reserves were the ones that survived.
That is wild.
Right. But today, we live in this environment that's just overflowing with high fructose corn syrup and purine-rich diets. So that ancient survival mechanism is now actively killing us.
That completely reframes how I view dietary triggers. It's literally an evolutionary mismatch. So without that enzyme, uric acid is really just a metabolic waste product for us now.
That's right.
It comes from the breakdown of purines, right? Both from the DNA in our own dying cellular turnover and from the protein we eat.
Spot on. Those purines get converted into hypoxanthine, then into xanthine, and finally into uric acid. And since it's water-soluble, our kidneys have to filter it out, with a small fraction degraded by gut bacteria.
Which brings us to the core mechanical flaw in a gout patient. We have to evaluate that balance of production versus excretion. I've always visualized this as a bathtub.
That's a great analogy.
Right, like the water level in the tub is your serum uric acid. If the bathtub overflows, it spills onto the floor, meaning it precipitates into the joints as crystals. And you can overflow for two reasons.
Right, the faucet or the drain.
Exactly. One, the faucet is turned up way too high, meaning your body is overproducing uric acid. Or two, the drain is clogged, meaning your kidneys are under-excreting it.
It's a perfect functional model. And the clinical reality is that 90% of your gout patients have a clogged drain. They are under-crickators. Only 10% are genuine overproducers.
Under 80%, okay.
Yeah, the vast majority. But honestly, regardless of whether the faucet is broken or the drain is blocked, once that tub overflows past 6.8 milligrams per deciliter, the uric acid starts to crystallize into monosodium urate, or MSU.
Which is where the fire starts. But, I mean, crystals just sitting there aren't inherently painful on their own, right? What actually pushes a patient from having silent crystals embedded in their cartilage into waking up screaming at 2 a.m.?
Think of the crystals as the kindling. The immune system is the match. Free monosodium urate crystals in the joint space are detected by local immune cells, specifically macrophages and neutrophils.
And their whole job is to attack foreign stuff.
Exactly. These cells are designed to recognize and destroy foreign invaders like bacteria. So they see these crystals and attempt to phagocytize, or eat them. But an MSU crystal isn't a soft bacterium. It's a microscopic, rigid, sharp needle.
Oh, man. So the neutrophil literally swallows a needle. That sounds like a complete disaster for the neutrophil.
It is a kamikaze mission. The neutrophil engulfs the crystal into its lysosome to try and digest it, but the crystal is completely indigestible. It physically tears the lysosomal membrane from the inside out.
Ouch.
Yeah, the lysosome ruptures, releasing these highly acidic, destructive proteolytic enzymes straight into the neutrophil's own cytoplasm, which
Yeah.
kills the cell. And as it dies, it bursts open, spilling all those corrosive enzymes, along with massive amounts of pro-inflammatory cytokines like interleukin-1, interleukin-8, and tumor necrosis factor alpha directly into the joint space.
So it's essentially shooting off a flare gun, calling in a chemotactic swarm of thousands more neutrophils, which all rush in, swallow needles, and burst open in this massive chain reaction.
That is exactly what happens.
That perfectly explains the explosive, rapid onset of the pain and the intense swelling. But why specifically the big toe? I mean, why doesn't this happen in the shoulder or the hip with the same frequency?
That comes down to basic thermodynamics. The solubility of uric acid is highly dependent on temperature. The core of your body is 37 degrees Celsius, your shoulder is warm, but your distal extremities, particularly your big toe, are significantly cooler. They sometimes drop to 33 or 34 degrees.
Ah, okay. Like how sugar dissolves better in hot tea than iced tea.
Exactly that. The cooler the fluid, the less solute it can hold before precipitation occurs. So the big toe acts as the perfect, cool, physical trap for crystallization. Add in the constant mechanical stress of walking, which causes microscopic tissue damage that acts as a nidus for crystal formation, and that first metatarsophilangioid joint just becomes the ultimate ground zero.
That makes total sense. Now let's look at the triggers, like who is pulling the trigger on this chain reaction. We mentioned diet, and knowing the evolutionary history, high fructose corn syrup makes profound sense.
It really does. The fructose metabolism rapidly consumes ATP, converting it to AMP, which breaks down straight into uric acid.
Wow. Then you have the purine-rich heavy hitters, organ meats, thymus, liver, and of course alcohol.
Yeah, alcohol is a double hit. Beer contains high levels of guanosine, which is a purine load in itself, but also the metabolism of any ethanol produces lactic acid. And lactic acid directly competes with uric acid for excretion in the proximal tubule of the kidney.
Oh, so it blocks the drain.
Exactly. The
Yeah.
kidney prioritizes getting rid of the lactic acid, so it leaves the uric acid trapped in the blood.
What about medication-induced gout? Because here's where it gets really interesting for us as pharmacists. We are often the ones dispensing the very triggers that set off the attack.
Absolutely. The most prevalent culprits are diuretics, both thiazides, like hydrochlorothiazide, and loop diuretics, like furosemide.
How do they trigger it?
Well, by artificially inducing volume depletion, they trigger the kidneys to frantically reabsorb sodium to maintain blood pressure. But in the proximal tubule, uric acid reabsorption is chemically coupled with sodium reabsorption. So as the kidney hoards sodium, it accidentally hoards uric acid right along with it.
Just dragging it back into the blood.
Exactly. We also see this with calcineurin inhibitors like cyclosporine, which we use in transplant patients. They cause renal vasoconstriction and drop the glomerular filtration rate, which drastically reduces uric acid clearance.
And then there is the aspirin paradox. This comes up all the time. If a patient comes in during a flare and asks if they should stop their daily baby aspirin, my instinct is to say yes, because aspirin is an acid, right? Doesn't it compete for excretion?
It does, but the mechanism is entirely dose-dependent, and it works in opposing directions based on the specific transporters it hits in the kidney.
Okay, break that down for me.
So low-dose aspirin, anything under 600 milligrams a day, which definitely includes your 81 or 100 milligram cardioprotectant doses, binds to and inhibits the OAT transporters. These are the ones responsible for secreting uric acid into the urine.
So by blocking secretion, low-dose aspirin traps uric acid in the blood and raises the serum levels.
Right.
But high-dose aspirin does the opposite.
Exactly. At high analgesic doses, we're talking 2 to 4 grams a day, aspirin actually blocks the uretine-1 transporter, and uretine-1 is responsible for reabsorbing uric acid back into the blood. So high-dose aspirin paralyzes the reabsorption mechanism, acting as a potent uricosuric, actively flushing uric acid out.
Wow. So back to the patient at the pharmacy counter. Do we tell our post-myocardial infarction patients to stop their 81 milligram aspirin during a flare?
Emphatically no. The cardiovascular benefit of secondary stroke and heart attack prevention infinitely outweighs the slight bump in serum uric acid. You manage the gout flare with other agents, you never stop the life-saving cardioprotective drug.
Okay, so the patient is in front of us. We know it's podagra, that classic first metatarsophalangeal joint involvement. It's warm, it's erythematous, and the pain peaked in intensity over a terrifying 6 to 12-hour window.
Very typical.
If they go to the emergency department, the physician orders a serum uric acid lab, and it comes back completely normal. I've literally had patients tell me, oh, the doctor said it's not gout because my uric acid is fine.
That is the diagnostic trap I mentioned earlier. During an explosive inflammatory flare, the massive surge in cytokines like interleukin-6 actually alters renal transport and temporarily increases the renal excretion of uric acid.
Oh, so the body tries to flush it?
Yes. Furthermore, the uric acid has precipitated out of the serum and deposited into the joint. The blood level drops because the joint is currently full of it. So a normal lab value during a flare tells you absolutely nothing. You have to wait until at least 2 weeks after the flare has fully resolved to draw a reliable baseline serum uric acid.
Good to know. What if a patient just toughs it out? They don't take anything, they just limp around for a week until the inflammation burns out, and they just do this for years. What happens to the joint?
If the underlying hyperuricemia is ignored, the disease progresses from acute, intermittent flares to chronic tophaceous gout. The body tries to wall off these indigestible crystals by wrapping them in giant cells and connective tissue, forming these macroscopic, chalky nodules called tophi.
Oh, those are awful to see.
They are. They take a decade or more to form, popping up on hands, wrists, elbows, Achilles tendons. And they aren't just cosmetically ugly, they physically erode the underlying bone and permanently destroy the joint architecture.
Just to make sure we aren't missing something more sinister at the counter, how do we definitively know it's gout and not, say, pseudo-gout or a septic joint? Because a bacterial joint infection is a massive medical emergency that will destroy the cartilage in hours.
Clinically, you look at the speed of onset, previous history, and joint distribution. But the absolute gold standard for diagnosis requires a joint fluid aspiration. If you pull fluid out of that swollen knee or toe and place it under a polarized light microscope, gout will reveal its signature. Monosodium urate crystals are needle-shaped and negatively birefringent.
Unpack negatively birefringent for us. What does that actually look like to the pathologist?
Under polarized light, the crystals act like microscopic prisms. When the long axis of the needle-shaped crystal is aligned parallel to the light filter, it glows a brilliant fluorescent yellow.
Oh, cool.
Yeah, and when you rotate it perpendicular, it turns blue. That visual confirms gout. If the crystals are rhomboid-shaped and positively birefringent, meaning they're blue and parallel, that is calcium pyrophosphate, which is pseudo-gout.
Got it.
And of course, if you see bacteria or a massive white blood cell count with no crystals, you immediately pivot to treating septic arthritis.
All right, so the diagnosis is presumed gout. We have a fire in the joint today. We need to look at acute gout management, which is heavily guided by the Australian ETG and international rheumatology algorithms. The golden rule here seems to be speed. Time is joint tissue.
Speed is everything. Pharmacotherapy must be initiated within 24 hours of symptom onset.
Real fast.
Ideally, yes. If a patient tries to wait it out for 3 days and then comes to you, our oral medications are drastically less effective because the cytokine cascade has already recruited an army of neutrophils. You have to shut down the signal before the swarm arrives.
Okay, so we have 3 pillars of acute therapy for a mild to moderate flare. Non-steroidal anti-inflammatory drugs, or NSAIDs, colchicine, and corticosteroids. All 3 are considered first-line monotherapy. But as a pharmacist, I'm not just grabbing one at random. My choice is dictated entirely by the patient's comorbidity profile. So let's work through some clinical puzzles.
Let's do it. There is no universally best drug, only the safest drug for the patient's specific organ function.
Right, patient 1, 65 years old, acute podagra, but their chart shows stage 3 chronic kidney disease with an eGFR of 35. My instinct is usually an NSAI for joint pain, but am I just trading a swollen toe for acute renal failure here?
You are absolutely risking pushing them straight into dialysis. NSAIDs work by blocking prostaglandins. In a healthy kidney, prostaglandins keep the afferent arteriole dilated to maintain blood flow into the glomerulus.
Right, so we don't want to mess with that flow.
Exactly. If you block them in a patient whose kidneys are already struggling, the arteriole constricts, renal perfusion plummets, and you induce acute kidney injury. So NSAIDs are completely contraindicated for this patient.
What about colchicine?
Colchicine requires aggressive dose reduction and extreme monitoring in CKD, making it pretty risky. Your safest, cleanest option here is a systemic corticosteroid like oral prednisone.
Okay, patient 2, 55 years old, totally healthy kidneys, but they have uncontrolled type 2 diabetes with an A1C of 9.2%.
Now the tables have turned. If you give that diabetic patient a 5-day course of high-dose oral prednisone, you will cause a massive surge in gluconeogenesis and insulin resistance. Their blood glucose will skyrocket into the 300s or 400s, potentially triggering diabetic ketoacidosis.
Yikes, so no steroids.
Right. For this patient, assuming normal renal and GI function, an NSAID or colchicine is strongly preferred to spare their glycemic control.
Makes sense. Okay, patient 3. They have a history of a massive upper GI bleed from a peptic ulcer 2 years ago.
Traditional non-selective NSAIDs are out. You might be tempted to use a COX-2 selective inhibitor like celecoxib to spare the stomach, but remember the cardiovascular risk we discussed earlier.
Oh, right, the endothelial dysfunction.
Exactly. Gout patients already have severe endothelial dysfunction. A COX-2 inhibitor can exacerbate cardiovascular events. So if it is a single large joint like a knee or an ankle, the most elegant systemic-sparing solution is an intra-articular corticosteroid injection. You put the drug exactly where the fire is, bypassing the gut, the kidneys, and the liver almost entirely.
That's perfect. What if it's a severe polyarticular attack, like they have gout in both ankles and a wrist simultaneously?
Monotherapy won't cut it there.
Yeah.
You escalate to combination therapy immediately. You can combine colchicine with an NSAID or colchicine with an oral corticosteroid.
Can I combine an NSAID with a steroid?
You must never, under any circumstances, combine oral NSAIDs with oral corticosteroids. The synergistic risk for a catastrophic gastrointestinal bleed is just way too high.
Great, Pearl. Let's look under the hood of these specific medications, starting with colchicine, which is commonly known as Colchris. You mentioned earlier it's not a painkiller. If I have a tension headache, colchicine won't do a thing.
Correct. It has zero central analgesic properties.
Yeah.
Colchicine is actually an incredibly old, highly specific antimitotic drug derived from the autumn crocus plant. It works by binding to tubulin, which is the structural protein that cells use to build their internal skeleton, the microtubules.
How does destroying the cellular skeletons stop a gout flare?
Well, neutrophils rely on those microtubules to physically crawl out of the bloodstream and into the joint space, a process called chemotaxis. If you prevent the microtubules from polymerizing, you essentially put a boot on the neutrophil's tires.
Ah, so they can't move.
Right. It becomes paralyzed. It can't migrate into the joint, and it can't extend its membrane to phagocytize the crystal. The inflammatory cascade is basically starved of its primary weapon.
But the dosing is incredibly strict. I remember when patients used to be told to, take a pill every hour until they had diarrhea. That sounds like a war crime now.
It was barbaric, and it literally killed people. The FDA-approved Acute regimen now is a strict low-dose protocol. 1.2 milligrams at the first sign of a flare, followed by a single 0.6 milligram dose exactly 1 hour later. That is a maximum of 1.8 milligrams for the attack.
And that's enough.
Yes. Studies prove this low-dose regimen is just as effective as the old high-dose regimen, but with a fraction of the toxicity. And again, it must be started within some 6 hours of symptom onset to be effective.
And we really have to counsel aggressively on that toxicity. Colchicine has a notoriously narrow therapeutic index. Because it stops cell division, it's going to preferentially damage the most rapidly dividing cells in the human body, right?
Which is the mucosal lining of the gastrointestinal tract. That is why nausea, vomiting, and diarrhea are not just annoying side effects. They are the crucial early warning signs of systemic toxicity. They precede the truly terrifying complications.
Like what?
Like bone marrow suppression, a granulocytosis, and neuromuscular failure.
And we are the gatekeepers for the drug interactions that trigger that toxicity. Colchicine is a major substrate for the CYP3A4 hepatic enzyme and the P-glycoprotein, or PGP, efflux pump. So if a patient comes in with a script for colchicine, and I see they are picking up clarithromycin for a sinus infection, or they are on verapamil for their heart, or maybe cyclosporine for a transplant, what happens?
Those drugs are strong inhibitors of CYP3A4 and PGP. They shut down the body's ability to clear the colchicine. The drug accumulates massively, turning a standard dose into a lethal toxic overdose. You must intervene, severely reduce the colchicine, or frankly just find an alternative acute therapy entirely.
Okay, let's move to the NSAIDs. Indomethacin has historically been the heavyweight champion for gout. Is there something chemically unique about indomethacin, or is it just tradition?
Mostly tradition. Indomethacin is an incredibly potent lipophilic NSAID that penetrates joint spaces very well, but it is notoriously harsh on the stomach and frequently causes severe CNS side effects like frontal headaches and dizziness.
So we don't have to use it.
Not at all. The modern clinical consensus is that other NSAIDs like naproxen, Sulindac, or ibuprofen are equally effective for gout, provided they are dosed at the higher maximum anti-inflammatory end of their therapeutic range for the first few days.
Good to know. Then we have our corticosteroids, prednisone, methylprednisolone, which is often dispensed as a Medrol dose pack, and intra-articular triamcinolone.
Right. For systemic oral treatment, you use prednisone at roughly zero point 0.5 milligrams per kilogram per day for 5 to 10 days, tapering if necessary depending on the duration. Trials have proven them completely equivalent in efficacy to NSAIDs, and they are a vital tool for patients with renal failure where NSAIDs are banned.
What about the really heavy hitters for refractory cases? The interleukin-1 inhibitors like anakinra, brand name Kineret, and canakinumab, brand name Aloris.
We use these when the patient's comorbidities rule out literally everything else, or when the flare simply won't break. Since we know the ruptured neutrophil releases IL-1 to act as the flare gun, these biologic drugs act as an interceptor missile.
Oh, that's a great way to picture it.
Yeah, administered subcutaneously, they bind directly to the IL-1 receptor, neutralizing the cytokine storm instantly. They are highly effective, but are reserved as last-line options due to cost and infection risk.
Okay, we put out the fire in the toe for today. The patient is pain-free. But how do we stop the house from catching on fire again next month? Getting the right acute drug is really only half the battle. Let's dig into long-term urate-lowering therapy, or ULT. First off, who actually gets a prophylactic drug?
The guidelines give us hard criteria for initiation. You strongly recommend starting ULT if the patient has any visible tophi, if an X-ray shows radiographic damage attributable to gout, or if they are suffering from 2 or more acute gout flares a year.
And what if they've only had one flare, just one terrible Tuesday night, and then nothing?
You generally hold off unless they have high-risk comorbidities. Initiation is conditionally recommended after a single flare if they have CKD stage 2 or worse, a massively elevated serum uric acid over 9 milligrams per deciliter, or a history of uric acid kidney stones. In those cases, the systemic risk is too high to wait for a second flare.
The absolute cornerstone of ULT is allopurinol, commonly known as Xyloprim. Let's look at the molecular mechanism. How does it stop the bathtub from overflowing?
Allopurinol works on the faucet. It is a structural analog of hypoxanthine. It binds to and competitively inhibits the enzyme xanthine oxidase.
Okay, so it stops the production line.
Exactly. By neutralizing this enzyme, it halts the biochemical conversion of purines into uric acid, forcing the body to excrete the more highly soluble precursors, hypoxanthine and xanthine, instead.
The dosing strategy here is critical. Start low, go slow. You typically initiate at 100 milligrams a day, or even 50 milligrams if the person has CKD, and titrate upward every 2 to 5 weeks. But why the slow roll? I mean, why not just hammer the enzyme with 800 milligrams on day 1?
2 reasons. First, a sudden, massive drop in serum uric acid will instantly precipitate a severe gout flare, a paradox we will discuss in a moment.
Yeah.
Second, you are trying to mitigate the risk of allopurinol hypersensitivity syndrome, or AHS.
Please describe AHS for the listeners because it is terrifying.
It is truly terrifying. AHS is a severe systemic immune reaction that can progress to Stevens-Johnson syndrome or toxic epidermal necrolysis. The patient develops a fever, massive hepatic and renal failure, and their epidermis literally begins to blister and detach from the underlying dermis.
Oh, wow.
Yeah, and the mortality rate is staggeringly high, approaching 20 to 25%.
But as pharmacists, we have a way to predict and prevent this, don't we?
Yes, the risk of this hypersensitivity is strongly genetically linked to the HLA-B5801 allele. The guidelines mandate that we screen high-risk populations for this genetic marker before ever dispensing the first pill of allopurinol.
Who falls into that high-risk category?
This includes patients of Southeast Asian descent, specifically Han Chinese, Korean, and Thai, as well as African American patients. If they test positive for HLA-B5801, allopurinol is absolutely contraindicated for life.
So if they carry that allele, or if they just can't tolerate the allopurinol side effects, what is our next move?
We pivot to febuxostat, brand name Uloric. Febuxostat is also a xanthine oxidase inhibitor, but it has a completely different non-carrying chemical structure. It doesn't cross-react in patients allergic to allopurinol.
That's convenient.
Very. You dose it at 40 to 80 milligrams daily, and a major pharmacokinetic perk is that it requires no dose adjustments for mild to moderate renal impairment.
I remember when febuxostat hit the market, it was hailed as this miracle alternative, but then a massive shadow fell over it regarding cardiovascular safety. Why did it get slapped with a boxed warning?
It stems from the CARES trial, which was a large, mandated cardiovascular outcomes study. The trial showed that while overall cardiovascular events were similar, patients on febuxostat had a statistically significant increased risk of cardiovascular death and all-cause mortality compared to those on allopurinol.
Wait, really? Why would inhibiting the exact same enzyme cause sudden cardiac death with one drug but not the other?
It's still fiercely debated. Some theorize that because febuxostat lowers uric acid more aggressively and continuously than allopurinol, it might cause more sudden, massive shifts in tissue oxidative stress, which temporarily destabilizes atherosclerotic plaques. Because of this data, the guidelines shifted to make febuxostat strictly a second-line option, reserved only for patients who have failed or cannot tolerate allopurinol.
Let's briefly touch on the drugs that work on the drain rather than the faucet. The uricosurics, like probenecid.
Right. Probenecid blocks the Urate-1 transporter in the proximal tubule, the exact same mechanism as high-dose aspirin, preventing the kidneys from reabsorbing uric acid and flushing it out into the urine.
But it has some pretty massive limitations.
Huge limitations. You cannot use it in patients who are naturally overproducers because flooding their kidneys with even more uric acid will instantly cause nephrolithiasis. It's contraindicated in anyone with a history of kidney stones. And practically speaking, it loses its efficacy once a patient's creatinine clearance drops below 50 millimoles per minute, which, let's face it, eliminates a huge portion of our gout population.
And for the absolute worst case scenario, like the patient covered in massive crippling tophi where oral drugs have completely failed.
We use pegloticase, brand name Cristexa. This is an intravenous infusion of recombinant mammalian uricase. We are literally giving the human body the enzyme it lost 15 million years ago.
That is incredible.
It really is. It rapidly catalyzes the solid uric acid crystals into highly soluble allantoin. It dissolves tophi at an astonishing rate. However, because it is a foreign animal-derived protein, the body forms antibodies against it. It carries a black box warning for severe anaphylaxis, and it is strictly contraindicated in patients with G6PD deficiency due to the risk of life-threatening hemolysis.
Okay, now let's address the most frustrating clinical pitfall in all of gout management. We have a target goal. The American College of Rheumatology says we treat to target, pushing the serum uric acid strictly below 6 milligrams per deciliter or below 5 for severe tophaceous disease. So you give a patient a prescription for allopurinol, they take it. A week later, they suffer the absolute worst gout flare of their life. They assume the drug is poisoning them, and they throw the bottle in the trash. Why did the cure cause the disease?
It's all about concentration gradients.
Wow.
When you start allopurinol, the drug rapidly halts production, and the serum uric acid level plummets. The blood becomes relatively empty, but the joints are still packed with solid crystal stores.
And nature abhors a gradient.
Exactly. The crystals start to dissolve and mobilize, shifting out of the cartilage and into the synovial fluid to try and equalize the blood concentration.
And the immune system sees all these freshly mobilized, shifting crystals.
Then it attacks them. The rapid shift in tissue urate stores directly precipitates the acute flare. This phenomenon absolutely destroys patient adherence.
So how do we prevent it?
Concomitant anti-inflammatory prophylaxis. When you initiate any urate-lowering therapy, you must co-prescribe a low dose of an anti-inflammatory, typically colchicine, 0.6 milligrams daily or twice daily, or a low-dose NSAID.
Like a shield.
Yes, this prophylaxis acts as a shield. It keeps the immune system suppressed while the allopurinol melts the crystal stores. You must continue this prophylaxis for 3 to 6 months after the patient achieves their target serum uric acid level, ensuring the joint is fully cleared of debris before removing the shield.
We rely so heavily on these prescriptions, but what about non-pharmacologic advice? Historically, patients were handed these draconian, strict, low-purine diet sheets. No meat, no fish, no joy. Just eat rice and suffer.
Yeah, and those strict low-purine diets are universally hated. Adherence is abysmal, and the clinical reality is that they're just insufficient. Even with perfect adherence, a strict low-purine diet might lower serum uric acid by 1 milligram per deciliter. It's simply not enough to cure a severe underexcretor.
So what actually moves the needle metabolically?
Broader metabolic health. Weight reduction in obese patients significantly improves renal excretion. Maintaining excellent hydration provides the fluid volume necessary for the kidneys to flush the uric acid. Entirely discontinuing alcohol, particularly beer, removes both the purine load and the lactic acid competition in the kidney. And massively reducing high fructose beverages prevents the ATP depletion cascade we discussed earlier.
The source material specifically points to the DHH dietary approaches to stop hypertension. It's rich in fruits, vegetables, and low-fat dairy, and clinical trials show it reduces gout flares more effectively than a standard Western diet, likely because it improves insulin sensitivity and endothelial function.
Exactly. It treats the underlying cardiovascular risk, which is what is actually going to kill the patient, not the toe.
We also need to be ready to debunk the over-the-counter myths at the pharmacy counter. Patients will constantly bring up gallons of tart cherry juice, celery root extract, and flaxseed.
The ACR guidelines explicitly state there is insufficient evidence to recommend any of these supplements. Tart cherry juice may have mild anti-inflammatory properties,
Yeah.
but it will absolutely not dissolve a tophus. They cannot replace allopurinol.
However, there are prescription medications they might be taking for their comorbidities that provide a synergistic benefit. If your gout patient needs an antihypertensive, losartan is unique among the ARBs because it has a mild uricosuric effect. If they need a lipid-lowering agent for triglycerides, fenofibrate also increases uric acid excretion. And incredibly, the SGLT2 inhibitors we use for diabetes and heart failure, like empagliflozin, have demonstrated reduced rates of gout flares, likely by promoting urinary glucose excretion, which drags uric acid out of it.
Choosing those specific comorbidity agents is a true hallmark of elite clinical pharmacy practice.
Bringing all of this together, what does this look like in the real-world workflow of a pharmacist? Imagine you are doing a comprehensive medication review. First, you check for interacting meds. Are they on a thiazide diabetic that we could ask the prescriber to swap for losartan? You assess renal function because their creatinine clearance dictates the safety of NSAIDs, the dose of colchicine, and the starting titration of allopurinol.
Right. And then for monitoring.
You ensure they are getting their serum uric acid checked every 2 to 5 weeks during the ULT titration phase to ensure they are hitting that under 6 target, and then every 6 months once stable. And if they are on febuxostat, you need periodic liver function tests.
But your greatest impact will be in overcoming the adherence challenge. You have to intercept their fear before it happens.
Definitely. Let's give our listeners some exact verbal scripts to use at the dispensing counter. For a patient starting urate-lowering therapy, you proactively frame the expected flare. You look at them and say, when you start this allopurinol, you might actually get a gout flare in the next few weeks. This does not mean the drug is failing or hurting you. It means the drug is working incredibly well to pull the old crystal deposits out of your joints. Do not stop taking the allopurinol. Use your daily colchicine exactly as we discussed to shield you from the flare, and call us if the pain persists.
That framing is brilliant. It turns a terrifying, painful side effect into a psychological sign of efficacy. I'll add a second verbal script for colchicine safety. Because of the narrow therapeutic index, you must say. If you develop nausea, vomiting, or diarrhea after starting this colchicine, stop the medication and contact your doctor or pharmacy immediately. This is an early warning sign that the dose is building up too high in your body, and we need to pause before it causes serious harm.
Those conversations literally save lives and save joints. Just to quickly recap our special populations. For the elderly whose kidneys and stomachs are fragile, you lean heavily towards short courses of oral or intra-articular steroids over NSAIDs or colchicine. For CKD patients, you meticulously adjust the allopurinol and colchicine doses and absolutely ban probenecid and NSAIDs. And for transplant patients, you hunt down those calcineurin inhibitor interactions that will skyrocket uric acid and colchicine levels into the toxic stratosphere.
It requires a holistic systems biology view of the patient's entire chart, not just their swollen toe.
Let's wrap up this deep dive with the absolute must-know takeaways for your next shift. Here are your rapid-fire clinical pearls. Number 1. Gout is fundamentally an issue of uric acid underexcretion, causing 90% of cases.
Number 2. Acute flares can present with a perfectly normal serum uric acid level due to cytokine-driven renal shifts. Do not fall for the diagnostic trap.
Number 3. Treat acute flares rapidly within 24 hours using NSAIDs, colchicine, or steroids tailored specifically to the patient's renal, GI, and diabetic comorbidities.
Number 4. Colchicine dosing is strict 1.2 milligrams, then 0.6 milligrams 1 hour later. Watch for GI toxicity as the primary precursor to severe bone marrow suppression.
Number 5. Do not initiate urate-lowering therapy for asymptomatic hyperuricemia.
Number 6. The target serum uric acid on therapy is strictly less than 6 milligrams per deciliter to ensure crystal dissolution.
Number 7. Always screen higher-risk demographics, including Southeast Asian and African American patients, for the HLA B5801 allele before starting allopurinol to prevent lethal hypersensitivity syndrome.
Number 8. You must co-prescribe flare prophylaxis, like low-dose colchicine, for 3 to 6 months when initiating ULT. ALT to prevent mobilization flares.
Number 9, do not stop urate-lowering therapy during an acute flare. It will only further destabilize the joint.
And number 10, low-dose aspirin for cardiovascular protection should not be stopped due to gout. The cardioprotective benefits vastly outweigh the minor urate retention.
Perfect.
If we connect this to the bigger picture, what if we stopped viewing gout purely as a painful joint disease and started treating it as a systemic warning siren? Given its intense ties to endothelial dysfunction, chronic kidney disease, and coronary heart disease, a gout flare isn't just a localized inflammatory event. It's an alarm bell for the patient's entire cardiovascular and metabolic system. Are we listening closely enough to what the toe is trying to tell us about the heart?
If you're looking for a quick, high-yield summary of gout and hyperuricemia, check out the quick dose version of this episode.